EGS, the student version, and the difficult open abdomen. Dr. Sugrue has many publications, more than 300 under his belt. And today he will be talking to us on EGS, who dares may not always win. Over to you, sir.
Hi, it's Michael Sugrue here, speaking to you from Ireland. I'm so sorry I can't be live on the webinar, but for different reasons I've taken the time to pre-record this and wish you all very well. I'd like to thank Roland, I'd like to thank Minturk, and to all my friends in Asia, it's great to be here. My talk is, Who Dares May Not Always Win. I'm going to look at transforming outcomes in emergency general surgery. I'm going to talk about our emergency general surgery report, which you will have received via email. And we call this Emerge. So the aim of my talk is to dare you to think into the future. I'm going to focus on the registry, and the second part of my talk will be on the emergency abdominal surgery course, EASC. I'm afraid this is me today. I'm in the High Court. It's much nicer to be on a webinar than being a witness in the High Court. What is clear is that facts don't change your mind. Friendship does. The Emerge, or the Emergency General Surgery Registry project, which we undertook over 3 years in Letterkenny University Hospital, is a start to a global solution in emergency general surgery. What we have done using a registry, which we're happy to share with you in time, is we've identified the patterns of emergency general surgery management. We've looked at a digital platform to understand the profile, and we will continue to work with Microsoft on this. We interrogate the way we manage emergency general surgery patients. We want to create evidence-based algorithms and decision aids to allow us to improve outcomes using key outcome indicators. We want to change the way we manage and monitor patients with introduction potentially of vital signs automation. And we want to create new educational opportunities, particularly through the emergency abdominal surgery course. And in the end, we want patient-related outcome tools. And this can be used by private insurers, but most importantly by patients themselves. What's unique about emergency general surgery, somewhat similar to trauma, is that patients presenting to acute hospitals, 70% have abdominal pain, and only 8 conditions account for 80% of this. In severe pain. Is that so there? Huh? These are real patients with real problems who are dying of peritonitis. It is our job as surgeons to salvage these patients. In Europe, there are almost 15 million emergency general surgery admissions annually. 2 million emergency general surgery operations, of which 400,000 are laparotomies. So the patient journey, it doesn't matter if it started in Manila Medical and you went to Ten Toc Seng in Singapore. It's all really about the patient and how they've done, their ability to get back to their home, their family and their work. So that journey is crucial. So when you're going down that trolley, pushing it or lying on it, there are some key questions that you want to know. What are my complications going to be? How am I going to be managed? Will it be monitored? Is there a quality program? Does anybody know what's going to happen to me? Well, we have some significant challenges that we need to improve on. We know our wound infection rates are about 15%, deep wound infection rate 3%, wound dehiscence 10%, seromas 20%, sinuses and associated pain. For pain alone, significant pain and 20%. Incisional hernias 30%. So I would put it to you in this collaboration in trauma across Asia, stop practicing our mistakes. We know from international collaborators through the NELA Group, the Royal Australasian College of Surgeons, the Asia Trauma Collaboration and many others, that there is a lack of data. From the UK, we can see emergency surgery talking about the standards for unscheduled surgical care. But we know that this is not unscheduled. emergencies happen 24/7. There's nothing unscheduled about them. So our current knowledge is limited. Great praise to the NELA group, who really set the analysis of outcomes from laparotomy with a 9.3% mortality. So, solutions. Emergency general surgery needs an overarching plan. Data is power. Outcome evaluation, the key, combined with education, performance enhancement, key outcome indicators, and we have defined those in the Performance Outcome Summit in Donegal in 2016. We have robust digital guidelines. We're developing AI algorithms to ensure that the human brain can be overridden. We have patient-related outcomes and patient-related experience measures. And we have resource optimization. Our ambition with a registry is to actually generate reports for surgeons like you and I, for hospital administrators that can actually monitor the outcome and tell us where we're going, provide a roadmap. This will alter care in 40% of our patients, reduce complications by 10%, and improve mortality by about 3%. So what we've done, and what I'm happy to share with you through Roland and Minturk and the group, is we developed a platform. We worked with Taka Consultancy Services, who have a very broad Asian profile, working globally now with 500,000 employees, have put together a data platform. With Microsoft, we are developing cloud-based applications through Digital Health in Ireland, and if we continue this data analysis, with more data that we get in, we can look at predictive analytics. Just to share with you what our registry does, and if we look at this, we have the registry, the pro forma reporting and decision tools. So if we want to enter a patient, this is a very simple registry based on MySQL, and you can start entering the patient's sex, age, duration of symptoms, abdominal signs. Fairly standard stuff for a registry. But what it will do is provide information that will allow predictors of outcome. We can actually use this to calculate clinical pictures combined with laboratory results to provide a likely diagnosis, such as a possible appendicitis, probable definite appendicitis, appendicular mass, or peritonitis. Coupled with the clinical and radiological features, this is an intuitive way to go. We need, for our emergency general surgery patients, for those who aren't digitalized, a pro forma. This can be a narrative combined with a guide, such as shown on the picture here. So our emergency general surgery registry has a minimum data set with a defined data dictionary, and we are happy to share this so that you can actually start your data collection. Data is the power to change. If we look at the 3,000 patients enrolled over 3 years that were admitted to our hospital in Letterkenny University Hospital in Donegal, we look at the time registered to triage, time to blood collection, time to referral, time to seen by the surgical team. Would you as a patient be happy to wait 2.8 hours to be seen by a surgical team? No. This data tells us we need to change. We need to look at the way we measure and monitor vital signs. Yes, of course, we have resource limitations in some countries, but what we need to do is think how we use existing resources, and it may be actually cost effective to use an automated vital signs monitor to free up our nursing staff to do more important things than just take the blood pressure. So when it comes to this, if we look at these graphs, you can see the red is the abnormal, the blue is the abnormal, and what we need to do is we need to have warning triggers. And these can be fed in combined with laboratory results to ensure that we have optimal outcomes, generating key outcome indicators for departments. In this case, our outcome indicator that an abdominal ultrasound should be completed within 24 hours of admission. Here, with the registry data, we can tell how well we're doing. We know, depending on the hospital, that ideally we should have a point-of-care ultrasound done on a patient in the emergency department. It'll help with our hospital organisation. Our AI algorithms will allow us to identify those that are going to do badly by running algorithms based upon laboratory results. Then it comes to digital archiving. So we need to actually be able to actually store our operative open and laparoscopic footage. We just published this paper looking at a synoptic overview using a digital potential pro forma in the World Journal of Emergency Surgery, just published for laparoscopic cholecystectomy. This is one of the first times this has been reported. It's now translated into Mandarin, Arabic, and it's something that we should look to because we need to be more detailed in our analysis. Working with Medtronic, we want to look at the OS1 system whereby we can actually store digital footage of our operations. Just like a CT scan, just like an MRI, we want it saved so that we can analyze the way we actually operate to improve outcomes. So when it comes to emerge digital requirements, it's like checking in for a flight. It could be Singapore Airlines, Malaysian Airlines. In our case, it's Ryanair. You don't hit the right button, you're not getting on the plane. With our recent 3-year project on the Emergency Surgery Outcome Advancement project, which led to the eMERGE Registry, we've just published over 40 articles, and they're available, most of them as open access. So moving then to education. The Emergency Abdominal Surgery course is now one of the emergency surgery's lead courses for both medical students, a different course, both virtual and real, for trainees and residents, a new course first run in India, in Mangalore, for consultants, and a new nursing course last year. What this course does, it takes common key conditions, appendicitis, diverticulitis, cholecystitis, large and small bowel obstruction. We look at the key probabilities, the facts of the case combined with the literature, with delivered short lectures combined with case discussion. The aim of the course, the Emergency Abdominal Surgery course, shares knowledge at all levels, consultant, trainee, resident, medical student. It provides tips on literature update, and it makes you, most of all, think. The course had its origin in Donegal, where I'm speaking to you from today. It's in the northwest of Ireland, that little red dot, beside Boris's country there on the right hand side. Our first course was in 2012. We followed this with a performance outcome summit in 2016 with many of the world leaders in emergency surgery, including, you can see, Lee Sheaf from New Zealand, a couple from Australia, some from India. Fantastic to now have a course that's run across the globe, and we're happy to look at sharing this with the collaboration in Asia on trauma. We have a medical student course, and here we can see the smiling medical students. Even the faculty are smiling because knowledge is priceless. Our advanced course was run for the first time, along with the 28th trainee course with Raj Mohan in Mangalore 3 years ago. And here we can see the trainees and consultants enjoying that course. So let's look at some key learning points on the Emergency Abdominal Surgery course. What is a course like this, which is confined to the lecture room, or it can be done virtually? Well, it gives you tips about appendicitis, about using a scoring index, about how you're going to manage a difficult appendicitis, how you're going to clip the appendix, how you're going to manage the stump, avoiding using drains, the use of energy devices. Then we go on to talk about operative difficulties and techniques with bowel anastomosis. We talk about diverticulitis, how the jury isn't in yet, and how potentially a lavage will reduce your stoma rate, but at a cost of increased reintervention. And the course goes through all the aspects of that. We look at abdominal wall closure, how to avoid stomal herniation, midline incision disruption. We look at stenting, and how is that going to fit into your practice? We talk about errors in the operating theatre, about understanding the use of equipment. We bring you up to date with the latest equipment supported by different companies. We challenge you to think about the ostomy that you're actually doing. Are you having a high parastomal hernia rate, and can you reduce that? Simple little technical tips. We talk about the open abdomen. How to get it open properly, how to close it, how to use mesh-mediated traction, and how to obtain better outcome tools with improved survival. We talk about common bile duct stones, how to manage them, how to diagnose them. But we go back a step, even to the simple cholecystectomy. EASC provides the information about the current facts, the approaches, who should have an index admission cholecystectomy. We know that we're managing this globally at a very variable pace. We know the importance of determining the presence and absence of common bile duct stones and managing them. From studies done in the UK, and the EASC course shares all this data. We talk about the importance of treating patients with gallstone pancreatitis with early cholecystectomy. Because data is power, and the registry, the eMERGE registry, can lend itself to automated reporting. Our first report came out in 2019 and our last report came out just last year. This will help avoid blind spots that we as surgeons have. Many surgeons will think choledocholitis or common bile duct stones are not a problem because 50% pass. But what we have to realize is that 50% don't pass and they cause a problem. EASC works with the World Society of Emergency Surgery, and we will be having a symposium on the Wednesday evening before the World Society meeting in Perth in Australia to share the latest knowledge with you to bring you up to date, and you're most welcome to attend that. We question the role of MRCP. How does that really help you in treating the underlying problem? EASC course goes through the tips in common bile duct exploration, laparoscopic and occasionally rarely open. We talk about traps, difficulties that we come into. We deal with case scenarios, and the case scenarios account for about 60% of the course with interaction through a faculty level, and this is really important. For us, whether it's a registry or an educational tool, such as the emergency abdominal surgery course, it's all about the patient, their family, and us working in a team to provide optimal care. So if we actually utilize a registry, we believe that we could reduce complications by about 40,000 in Europe alone and save 12,000 lives annually. However, despite the tools, the registry and the data, who dares does not always win, because we are slow to implement. So in conclusion, Roland, Minturk and my colleagues across Asia, and my fellow speakers, a functioning registry can transform emergency general surgery care culture. We should work together, and we will be delighted to look at sharing the emergency abdominal surgery course to provide a unique platform to share knowledge. And this can be modified to the need and resources of different regions. So from Michael Sugrue in Donegal in Ireland, thank you so much, and I'm looking forward to a replay when I come out of court to hear the rest of the speakers today. Thank you so much.
To give the reactions on this talk, it would be Dr. Sanjay Shah. He is the consultant trauma surgeon at the Apollo International Hospital, Gandhigarh, India, and he is the head of the emergency department. He has been the first qualified trauma surgeon in India and has been the course director and a faculty member of the ATLS of India. He has many research publications related to acute surgery, including trauma, and he would be delighted to provide his reviews and reactions about whatever the interesting experiences that shared by Dr. Michael Sugrue. Over to you, Dr. Sanjay Shah.
Thank you very much, Asian Collaboration on Trauma, for giving this excellent opportunity. And we had very elaborative and excellent presentation by Professor Dr. Michael Sugrue. He talked about emergency surgery. Also, he talked about importance of registry and one of the very important course of emergency abdominal surgery course. Now, in Asia, yes, we or most of the surgeons do acute care surgery or emergency general surgery very often. What we are lacking right now is having a registry of it. Of course, it will help us and lead us to a common consensus where guidelines can be shared with Professor Sugrue's suggestion of European algorithm. And I know about trauma registry that more than 3 or 4 hospitals, along with AIMS Hospital, from where Dr. Amit Gupta is, they have collaborated with the Australian registry for making a trauma registry. But that we are yet to go on as far as emergency general surgery, because it's a lot of patients. Not to underestimate the importance of patients who are undergoing for emergency abdominal surgery, and the importance of that emergency abdominal surgery course would be very, very helpful for surgeons, particularly in the settings where a patient has already undergone for previous laparotomy for one or the other reasons, or having stoma and getting some another surgery for other indication, or for trauma scenarios. Patients who have undergone for previous mastoplasty for a large incisional hernia, and now patient is having underlying peritonitis and he is requiring laparotomy. And certain scenarios where I would like to have opinion about patients of comorbidities like having portal hypertension or cirrhosis or end-stage liver disease and requiring emergency abdominal surgery. So these are the subset of the patients where definitely such course will help us to teach general surgeons in how to go ahead with such kind of scenarios, whether it is underlying peritonitis or trauma and patient is requiring laparotomy. So every surgeon should know when to operate, when not to operate, particularly when we have a minimally invasive intervention in our armamentarium, like angioembolization or percutaneous drainage. Having said that, laparotomy is a mainstay of for a surgical disease like peritonitis, perforated appendix, diverticulitis, and all. And as Professor has mentioned regarding when to put drains, when not, when we have to create stomas, how to manage the consequences and complications of stomas, all that will be taught in emergency abdominal surgery course, and it would be really helpful for a surgeon if he undergoes training of such protocol-based course management, particularly surgical residents. Also, we do have AI coming in a big way, particularly, and then this data digitalization is very, very important. Having said that, yes, we do have challenges of safety of this data and bias of this data, because Asian people would have a different underneath problems as well as diagnostic issues. So we'll have to design a separate set of questions, putting this digital algorithm to lead to diagnosis. And if we can work with this European guideline and modify it as per the Asian requirement, yes, it will help us significantly. And this AI and AI-based algorithm will definitely solve the issues in preventing delays in expert referral, as well as early diagnosis and monitoring or rather automation of the vital signs. Thank you very much, and we'd like to have an opinion of the house for the whatever questions we have.